My name is Allison Bitter. I'm a physician assistant here in the bone health clinic at Iowa Ortho. I'll give you just a little bit of background around me. I'm originally from Dubuque, Iowa, where I went to PA school as well at the University of Dubuque. Then ended up in Mason City practicing orthopedics for about a year after school. And now I'm down here at Iowa Ortho. Joined here, I think it was mid-March, so for a couple of months now. Today, I'll be walking you guys through just a little bit about osteoporosis, what it is, how it's diagnosed, and then we'll finish off with some of the treatment options I use here for osteoporosis. So osteoporosis, if you break the word down, literally means porous bone. Osteo is the fancy word for bone. So porous bone, meaning weakening of the bones, making them more likely to break. Osteoporosis occurs when our body loses too much bone, produces too little bone, or oftentimes a combination of both. So it's a problem with both the quality of the bone as well as the quantity of the bone. And I'll get into that a little bit more in a couple of slides when I talk about the diagnosis of osteoporosis with a bone density scan. So some facts about osteoporosis. It's quite prevalent, estimated that about 10 million Americans have osteoporosis. Definitely hits women harder than men. Women will lose up to 20% of their total bone mass in the first 5 to 7 years after menopause. Reason being, estrogen has a protective effect for our bones. So once women lose that protective effect of estrogen, they start to lose bone at a much more accelerated rate than their male counterparts. 1 in 2 women and 1 in 5 men over the age of 50 will suffer a broken bone due to osteoporosis. And once an osteoporotic fracture occurs, that person is 5 times more likely to suffer another fracture within the first year after. So it's a much more prevalent disease than oftentimes we realize. And it's often called a silent disease. Reason being, osteoporosis doesn't hurt. There's no symptoms of it, unfortunately, until a bone breaks, essentially. So what are some of the causes of osteoporosis? There are some lifestyle factors. Excess alcohol consumption, as well as tobacco use, have a negative impact on our bone health. Poor nutrition, things like calcium intake, vitamin D intake, magnesium, protein, all important things that we need in order to build bone. A sedentary lifestyle and a lack of exercise certainly takes its toll on our bones as well. Having a low weight actually is a risk factor for osteoporosis as well. So it's very important to maintain a good, healthy weight. There are some medical conditions that we know predispose us to having weaker bone, including diabetes, cancer, because treatment with chemotherapy and radiation negatively affects our bones. There are a whole lot of medications that negatively affect our bones as well. Some of those being steroids like prednisone, anti-GERD medications for heartburn, such as omeprazole and antacids, seizure medications, antipsychotics, all kinds of medications out there that we generally don't realize can increase our risk of osteoporosis. And then as well as problems with the kidney, liver, or digestive system can all affect our bones as well. So there are a whole lot of things that can increase our risk for osteoporosis that we take a look at. Some of the biggest risk factors that I consider and I talk to my patients about, the number one being history of broken bones. The number one predictor of breaking a bone in the future would be, have you broken one in the past, particularly a wrist, an arm, a hip, a femur, those kinds of broken bones. Height loss, we always measure our patients and compare that to how tall they've ever been in their life, the maximum height. A family history of fracture. We know that when someone has a parent who has broken a hip, that puts that person at a 7 times greater likelihood of breaking a hip in their lifetime, especially if that hip fracture was before the age of 80 in the parent. Smoking, as I touched on before, especially, considering duration of smoking and how much smoked, definitely negatively affects bone quality. low weight, as I touched on before, and then postmenopausal. Again, that estrogen protects our bones. So once us females lose estrogen and go through menopause, it's normal to lose about 3% of bone mass per year, compared to males who continue to lose only about 1% of bone mass per year. So some things that are modifiable there and some things that, of course, aren't modifiable. How we diagnose osteoporosis officially is with a bone density scan. So when our patients come in, the first thing they do is they go downstairs and get a DEXA bone density scan. So what is that? Basically, a fancy machine that measures, that sends a certain amount of energy via wavelengths through certain areas. Where we look is one of the hips and the lumbar spine. Then it's capable of measuring how much of that wavelength passed through the bone. So essentially, if the bone is very porous, like that picture on the right there, you could imagine that more energy would pass through it, versus if the bone's nice and strong and dense, not much energy should pass through it. So there's kind of an inverse relationship between how much passes through there and the strength of our bones. And then we use criteria set by the World Health Organization regarding, once a certain amount passes through, you do receive a diagnosis of osteoporosis. So once you have a diagnosis of osteoporosis, we talk about treatment options. Why treat osteoporosis? Someone might come in and find out they have osteoporosis and they might say, well, I've never broken a bone before. The whole point of treating osteoporosis is to prevent broken bones. Lowering the risk of breaking bones equals increased quality of life, as well as maintaining that quality of life, maintaining independence. More than half of people over the 80 with hip fractures will end up in a nursing facility long-term, as well as it decreases morbidity and mortality associated with those fractures. So when it comes to treatment, there are kind of three categories of osteoporosis treatment options we can use. There are anti-resorptives and anabolics, and then a combination of both. So what I mean by those is basically our bones are constantly in a recycling process our whole lives long. They're constantly breaking down old bone and building up new bone. So treatment for osteoporosis focuses on either one side of the equation or the other, with the exception of one medication called Evenity that actually focuses on both. So anti-resorptives tie up a specific enzyme in the body that stimulates bone breakdown. So by holding that enzyme back, it lessens the amount of bone we're breaking down. Anabolics work on the right side of the equation in that they actually help us build bone up. And then Evenity, like I said, is a newer medication that's the only medication that works on both sides. So it actually helps you break down less bone and build new bone up at the same time. So the anabolics there called Forteo and Tymlos, I'm just not going to get into much. They're newer and they're just not very well covered by insurance. So I usually have a pretty significant barrier with those with cost. The two that I use by and large most commonly are Prolia up there under the anti-resorptives, and then Evenity, which is the one that does both. So those are the two I'm going to touch on real quick here. So probably use Prolia the most often. Like I said, that's an anti-resorptive, helps us slow down the bone breakdown process so that it gives us a chance to actually build some bone up. So what that is an injection into the arm given by me every 6 months, so just twice a year. 3 years of treatment with Prolia has been shown to reduce the risk of new spine fractures by 68%. So that's a pretty significant fracture risk reduction with that. Basically, we do 5 injections, so that equals 2.5 years. And then we repeat the bone density scan so that we can look and compare and hopefully determine how much improvement is being made. Once those bone density scan scores come up high enough, we then determine we can stop the Prolia. But it's a very safe medication overall. It's been studied out to 10 years. I have patients in this clinic who have been on it for 8 years straight with no problems. But possible problems with it, the number one thing being a pretty benign thing in that it can lower the calcium level in your blood just a little bit. That's that word there called hypocalcemia. So basically we monitor our patients calcium levels with a blood draw yearly. If it drops too low, you can get things like muscle cramps, joint pains, aches, and those kinds of things. And those are the most common side effects of Prolia. The one potentially serious but rare side effect with Prolia is a fancy word called osteonecrosis of the jaw. Basically means kind of a wound or an infection in the back of the mouth that can get into the jawbone. So serious when it happens, but incidence is about 1 in 10,000. So what I always tell my patients is if you're going to be having any major dental work done, meaning an extraction or an implant, to let me know, then we'd put the Prolia shot off a month or two until it's healed up, and that further minimizes that risk. So that's Prolia, very good medication. Generally, people don't feel any different on it, very, very low side effect profile, and works well. And then Evenity came out, a little bit newer than Prolia, and it's a very, very good medication. Works as both an anti-resorptive and an anabolic. So it's stopping that bone breakdown and helping you actually build bone up as well. So Evenity is a little different, and that's an injection into the arm every month for 1 year. After that 1 year of treatment, we repeat a bone density scan, and we see increases in bone mass with Evenity after 1 year that are far greater than the increases we see with Prolia after 2, 3, 4, even 5 years. It's a great medication. It helps you build bone like crazy, and works very quickly. The only downfall with that, it is currently only approved for females, so I can't use that one in my male patients. But 1 year of treatment with Evenity reduces the risk of new spine fractures by 73%. So higher percentage in 1 year of treatment than Prolia is with 3 years. So awesome medication, generally pretty well covered by most insurances, especially Medicare. But the one thing Evenity has that Prolia doesn't have is a black box warning for potentially increasing the risk of cardiovascular events. And by that, I mean heart attack and stroke. So it's recommended not to use the medication in females who have had a heart attack or stroke in the past year. A little bit of background, though, about that black box warning. I usually explain to my patients, back when Evenity was coming out, there were 3 very, very large trials. In 2 of the 3 trials, there was no correlation with heart attack or stroke at all. It was just the smallest of the 3 trials that found there was a slightly larger risk or incidence of heart attacks with the Evenity group than with the placebo group. However, when they looked at that rate compared to the general population in America outside that study, they didn't find it to be any different at all. So then they brought in a team of cardiologists to evaluate this and officially then ruled that this was due to chance. The warning hasn't been lifted yet. There's talk about lifting it in the near future. I still err on the side of caution and don't use it in any patients that have had a heart attack, just to be on the safe side. But that's the one thing to know about Evenity. So Evenity, 1 year of treatment, build bone like crazy, repeat a bone density scan. And then the thing with Evenity is at that point, you then have to transition to Prolia in kind of a step down fashion. Can't just stop after the Evenity or you'll quickly lose a lot of the bone mass you gained. So then generally just a course of 5 Prolia injections, and then I'm able to take people off of it thereafter. So that's basically the quick rundown of the 2 medications I use probably about 95% of the time. I do use the oral pills every now and then. Back here on this page, the oral bisphosphonates. Many people have heard of Fosamax or alendronate. That's a once weekly pill you can take. Been around for quite a while, a cheap medication, works, doesn't work as well as Prolia or Evenity, and there are greater side effects with that. So I tend to shy away from it unless there are absolute contraindications with the injectable medications, or if someone's against receiving injections. So that's basically the overview of what patients we treat for osteoporosis, how we treat them, how we monitor, things to watch out for, and why we care so much about treating osteoporosis.